The radial nerve is a continuation of the posterior cord of the brachial plexus. It is the largest nerve of the brachial plexus, and it supplied the posterior compartment of the upper limb. It carries fibers from C5, C6, C7, C8 and T1 of the brachial plexus. So, how do we remember brachial plexus? Brachial plexus is divided into roots, trunk, division, cords and branches. Under root, C5, C6, C7, C8 and T1, in which C5, C6 joins to form the upper trunk, C7 forms the middle trunk, and C8 and T1 forms the lower trunk. This further, from the upper trunk and the middle trunk, from the upper trunk you get an anterior division and the posterior division. From all three trunks, anterior division and posterior division, which further goes on to form from the upper trunk, the anterior division is formed by the lateral, and the middle trunk forms the anterior division, forms the lateral cord. The posterior cord is formed by the upper trunk, middle trunk and the lower trunk from the posterior division. And lastly, the lower trunk is formed by the middle cord, anterior division of the middle cord. This further, from the posterior cord, here comes the axillary nerve and the radial nerve, which further gives branches, that is the musculocutaneous, axillary nerve, radial nerve and medial nerve and ulnar nerve. A mnemonic is MAMU. The course in the axilla, the radial nerve lies posterior to the third part of the axillary artery and anterior to the muscles forming the posterior wall of the axilla. It gives off three branches: posterior cutaneous nerve of the arm, nerve of the long head of the triceps, nerve to the medial head of the triceps. Coming on from the course of the radial nerve, from the arm, it enters at the lower border of the teres major and passes between the long head and the medial head of the triceps to enter the lower triangular space. This is the course. The branches in the spiral groove are the muscular, cutaneous and the vascular. At the lower third of the humerus, it pierces the lateral intermuscular septum to enter the anterior part of the arm, and it lies between the brachialis medialis and brachioradialis and extensor carpi radialis longus. It gives out three branches on the lateral side of the arm. There is the brachioradialis, extensor carpi radialis longus and lateral part of the brachialis. Coming on to the forearm, it enters the forearm and the radial nerve moves anteriorly over the lateral epicondyle of the humerus, and in the cubital fossa it terminates into two branches. There is the superficial branch and the deep branch, also known as the PIN, posterior interosseous nerve. So the superficial branch of the radial nerve mainly supplies the skin over the anatomical snuff box, lateral half of the dorsum of the hand, and then lateral 2.5 digits until the PIP joint, as seen in the figure here. This is the sensory. This is the cutaneous innervation from the radial nerve, from the arm to the hand. Radial nerve injury can be at various levels. That is at the axilla, which is a very high lesion, which is mainly caused because of dislocation, glenohumeral dislocation, fractures of the proximal humerus, and known as a crutch palsy. In patients who have fractures, they walk with crutches. The deficit here will be the triceps weakness will be present, brachioradialis and wrist joint palsy will be present. there will be a finger drop and thumb drop will be present. At a radial groove, which is a high lesion, maybe because of fracture shaft of the humerus, Saturday night palsy, injections or tourniquets. Here there will be brachioradialis weakness, wrist drop, finger drop and thumb drop. Sensory loss will be present over the extensor surface of the arm, which is spared, and forearm is sensibility may or may not be spared. Coming to a low lesion, fracture of the radial head, posterior dislocation of the radius causes this. Here there will be deficit at the posterior interosseous nerve. We will not find any wrist drop present here, but finger drop or thumb drop may be present. There is no sensory loss. So these are the three at the very high lesion, in which at the axilla it will occur, high lesion at the spiral groove, and at to the posterior interosseous nerve, which is a low. Second last row. आ जाओ जल्दी. At the axilla there is weakness, tingling and numbness from the back of the arm of the hand. To the spiral groove there is weakening of the brachioradialis muscle of the muscles of the forearm. Interferes with the person's ability to bend the wrist back and straighten the fingers. And a low lesion that is affected is the posterior interosseous nerve. There is muscle weakness and ability to extend one's finger. क्या नाम है? रोल नंबर क्या है? क्यों? Coming on to classification of nerve injuries, Seddon's classification is divided into three, that is the neuropraxia will be present. Here there is temporary paralysis of the nerve caused by lack of blood flow or by pressure on the affected nerve with no loss of structural continuity. Exontemesis, in which there is a neural tube defect but axons are disrupted. Here the nerves are likely to recover. And neurometasis, in which neural tube is severely affected and there is permanent damage without repair. How do we clinically diagnose this? Clinical assessment is done, in which there is inability to extend the thumb. Anyone knows what is a hitchhiker sign? This is a hitchhiker sign. Inability, there will be inability to extend the thumb in radial nerve injuries. Thorough knowledge of the course of nerve and muscle is supplied should be assessed. We can find it out by imaging, that is USG and MRI can be done, and also a Tinel sign can be performed in this. This is what is Tinel sign? It is a transient tingling sensation will be present. You hit over the nerve, and this should be felt by the patient in distribution of the injured nerve. We can also perform electrodiagnostic studies, that is electromyography can be done, sampling of the involved extremity with needle pick up electrodes that yield information regarding neuropathic injury and pathology. Nerve conduction study can be done, in which F-wave studies are specially useful for investigating peripheral nerve injuries that are more proximal and less accessible through other techniques. उसको भी ले जाओ बगल वाले को. The management here is conservative treatment options depend on the severity of the injury and patient symptoms. Analgesic medications include oral or topical NSAIDs, in which you can corticosteroid injections can be given and steroids can be done. We maintain a full range of motion and we apply a radial splint, also known as a dynamic cock-up splint. In cases of nerve injury that cannot be repaired, early exploration is needed to check and manipulation is done, especially in open fractures. and when it is associated with vascular injury. The principles here is prepare a nerve stump or a graft, and Millesi gap is the gap in which nerve cannot be repaired even after stretching of the nerve. If it is more than 2.5 centimeters, greater or more than 2.5 centimeters, indicates possibility of tension. Depending on the duration of primary repair is done within hours, which helps a lot. Delayed primary within 5 to 7 days, and secondary in more than 7 days. This is nerve repair techniques, in which in the first diagram you can see the epineuron is repaired. In the B figure, epineuron and the perineuron is repaired. In the third, neural sutures are taken, and in the fourth figure, graft has been applied. Nerve grafting is usually applied when there is a gap of around more than 10 centimeters, and the most common nerve used here is sural nerve. This is the diagram of the nerve graft. Second complication here is radial tunnel syndrome. Radial tunnel, the entire lateral epicondyle to the arcade of fascia is affected, mainly because of compression. This can be causes nerve compression in Monteggia fractures, radial head fractures. So the patient will present with pain and inability to extend the finger against resistance when the elbow is extended and forearm is pronated. There will be weakness of wrist extension. Provocative tests that can be done here is painful resisted supination and painful resisted middle finger extension test. How do you evaluate this? With MRI and NCV. The treatment here, conservative and rehabilitative treatment, comprises of splinting, done in extension mainly during the night for 4 to 6 weeks. Activity modification can be done, stretching and strengthening of program under physical rehabilitation, and local steroids can be given, corticosteroids can be given. You can also perform surgical techniques, that is surgical decompression can be done if the pain persists for more than 3 months of non-operative treatment. Wartenberg syndrome, also known as Caralgia paresthetica, also known as the handcuff neuropathy praxis. It is the compressive neuropathy of the superficial sensory nerve. There will be no motor deficit here, and numbness will be present over the posterior aspect of the forearm. Here the posterior interosseous nerve, that is extension of the radial nerve as it comes into the forearm. There will be no sensory dysfunction, and in PIN compression syndrome, pain part is missing, while the motor weakness is the predominant syndrome.